Hello, everyone, and welcome to the first debate that we are having in Health System Science 2. So today, I've got two very distinguished guests who are joining us today, people that you are familiar with. On the one side, we've got Professor Kevin Behrens from the Steve Biko Center for Bioethics, and we also have Professor Catherine Burns, who's joining us from the Adler Museum as a medical historian. So, hi there, Kevin, and hi, Catherine. How are you doing?
Well, thanks, Stephen.
So thanks for joining us and for taking this opportunity to show the students how we structure some of our arguments and think about how we might counter what arguments are presented to us. Before we start with our debate, what I would like to remind the students to do is to take notes of the different points that are being raised by the speakers, and have a piece of paper in front of you. And as you listen to this conversation, note what you think are the key points that are being raised. You can also then take note of how those points are being rebutted. So the counter argument that might be being put against what is being said. The topic for today's discussion is as follows. We're talking about Depo-Provera, which is the topic of your ethics essay. And despite Depo-Provera being the most frequently used injectable contraceptive in South Africa, women should be fully informed about its controversial history before being prescribed this drug. Can I hand over to Kevin? What is your response to that statement?
So Stephen, firstly, I think I'd like to just question the way in which this question, the statement is being framed. Because what it seems to be suggesting is that just because the use of this drug has a history that is obviously grounded in a great deal of injustice and things that we would these days look back at and consider morally wrong, and in possibly even in racism, looking at it in that way is just wrong-headed. And the reason it's wrong-headed is because the history of how it was used has got absolutely nothing to do with how it's currently being used. And just because something was used for the wrong reasons in the past, perhaps for population control reasons or whatever, has absolutely nothing to do with its use by a democratic government over the last 25 years since we have been a democratic country, in its attempt to help women, to provide them with a reliable contraceptive, and one which frankly most of them prefer anyway. So I honestly think that to waste health professionals' time, given how pressed they already are, with having to inform people about the history of the use of this drug is utterly nonsensical. In addition to that, the WHO does recommend the use of this drug. At least it endorses its use. And it's obviously regarded as relatively safe. So there could be arguments about possible side effects or harms to people, clearly, but that is going to be the same for pretty much any of the contraceptive options that are available. So all that's necessary is the same standard informed consent that would be required for anything else, and that is that patients need to be told what their options are, what the benefits and what the possible harms are from each of those options. And then finally, I just want to say that I honestly think that this requirement of explaining the history of the use of a drug to patients is just far too onerous. Given the reality that we face with already overstretched resources in our healthcare system, they already struggle just to talk about the effects of the drugs that they're offering, to give their patients information about their treatment, to expect them now also to become little qualified historians, and to be able to convey the history clearly, is just asking way too much. So I'm really concerned that we're really wrong-headed here, and we're essentially wasting our time on something that is simply no longer relevant.
Thank you for those points, and they're indeed really interesting. Catherine, do you have a response to what Kevin has raised?
Absolutely. I think Kevin raises some very important points, but I think overall I strongly disagree with his argument, and I'd like to show why. The context and the history of how medicines and drugs come to be used has a huge bearing on their efficacy and on the way that people enact that particular kind of procedure in their lives. It has a biological effect and it has a social effect, and it therefore carries moral weight, and it goes right to the point of choice. Our Constitution guarantees men and women choice over their reproductive decisions and over their fertility. In order to make an informed choice, people come to a particular set of circumstances, and they carry with them their sociological and their historical understandings. We don't have a lot of time here to be able to lay out why it is in the first place that women are held almost entirely responsible for fertility decision-making when it requires obviously biological male and female persons to conceive of a child. So leaving aside that, and that's an implicit assumption that we already come to this debate with, we have to ask ourselves if Depo is something that should be part of a basket of choice. Why is it that overwhelmingly Black women in South Africa use Depo-Provera in the public health service and no other contraceptive? And why is it in private care and in public and in private spaces, white women and women of Indian descent and women of mixed background hardly use Depo at all, and Black women are not offered Depo as a choice inside of private care? So there are obviously highly complex population level contextual reasons why Depo is still overwhelmingly the drug used for contraception amongst South Africa's majority population of women. And in order to understand why that's so, we have to look at behavioral messages, we have to look at what healthcare providers think is their target population, and we have to also think of the way in which the drug has become acceptable to people in their communities in a cultural and a systemic way over 4 or 5 decades. So it's not incidental at all to its current use that the apartheid government in the mid-1960s decided to target this hormonal contraceptive of Black women and made this public knowledge by the 1970s. It's not incidental to its history that people in the Black consciousness movement specifically were aware of this, and they mobilized community responses about this in churches and in activist groups and in trade union groups and in youth movements. And it's not incidental that the health minister appointed by Nelson Mandela in 1994, Dr. Nkosazana Dlamini-Zuma, who's still a very important member of the South African cabinet and of our government, went to a huge Beijing conference and argued that Depo-Provera had to be demoted and made available possibly, but inside of a much bigger basket of options for women. She made a speech at the Beijing conference in which she committed her government to making sure that Black women would always be offered other choices in South Africa as other women had been. And she insisted that the history of Depo's use needed to be brought to the attention of all South African women and men. The controversies that have dogged Depo in South Africa and in other developing countries ever since came to a head in 2012-2013 when a consortium was set up to actually examine what the untoward effects could be of Depo that weren't recognized in the 1960s and 70s because of the vulnerability that seemed to be linked to Depo use and HIV acquisition. HIV didn't exist, or it wasn't known about in the 1960s when Depo's efficacy and safety was established, at least to the benchmark level of other hormonal contraceptives. But over the course of the last 15 years, a huge amount of data has emerged, including by leading WITS reproductive health scientists, that Depo carries unacceptable vulnerability for bone mineral density, for inflammation, for obesity, for hypertension, and for several other comorbidities. And so the ECHO trial set out to try and establish whether this was accurate or not accurate. In 2019, they released their limited findings, and the WHO, you're quite correct, Professor Behrens, decided that Depo should still be part of the basket of care of different kinds of contraceptives available to women in the developing world and the developed world. But there has been, for 18 months now, a very, very lively debate in the scientific community, which all hinges on whether or not the Depo trial was the ECHO trial was sensitive enough in determining the untoward effect or link between Depo use and HIV susceptibility. But the broader issue still remains. Depo-Provera is a drug that has been targeted historically at Black women and women in the Southern Hemisphere of the world. It's a drug that carries heavy side effects. These are not side effects that richer women and women in the Northern Hemisphere have found tolerable. South African women are not offered a wide range of options. We have to question, therefore, whether their decision-making when they are offered Depo-Provera is part of a broader pattern, and therefore historical evidence weighs very heavily on the patient-client decision-making moment.
Thank you for sharing those very compelling arguments, Catherine.